All right. Sorry about that, everyone. We're going to go ahead and get started. So welcome to Medical Grand Rounds. Just real quick, since we're a little bit late, on March 6th, we have the Distinguished Collins Lecturer, Elaine Worcester, coming from the University of Chicago. On March 13th, the Brettel Distinguished Lecture, which is our own Lottie Derby. Really, I'm very pleased to welcome Dr. Sarah Rowan here today. Dr. Rowan is an associate professor of medicine in the Division of Infectious Diseases and the associate director of HIV and viral hepatitis prevention at the Public Health Institute at Denver Health. She provides her clinical care at Denver Health as an outpatient infectious disease specialist for persons with HIV. She attends the Denver Health STD clinic and staffs the inpatient ID consult service, also at DH. Dr. Rowan is also a consulting physician for medical aid and dying program at Denver Health, and she is the recent past chief medical officer of the Jefferson County Public Health Program. She was an undergrad at Tulane University, did her medical school at the University of Oklahoma. She was a medicine pediatrics resident at Yale University and was an ID fellow here at Colorado, where we've been lucky enough to keep her now for several years. She truly is an international expert in the complications of infectious diseases. She has an extensively funded research career, currently serving as the PI, co-PI, or collaborator on grants from the CDC, the NIH, the NIDA, and the National Institutes of Mental Health. And she really is a tireless mentor, speaker, and in particular, an advocate for all that she does. She currently serves on the 5280 Fast Track Cities Task Force to End the HIV Epidemic Action Group, Colorado's Strategic Plan for Viral Hepatitis Elimination Coalition, the National HIV PrEP Curriculum Advisory Board, and she sits on the joint UN Fast Track Cities Initiative to end the HIV/AIDS epidemic by 2030, among many other things. Truly is a pleasure to welcome Dr. Sarah Rowan.
Remind me how I advance the slides. Oh, there we go. Okay, arrow. All right, thank you all so much for coming. Thank you for the opportunity to talk about this topic. I hope everyone can get their CME. Thank you to my former mentors from infectious disease for being here in the audience. This is a topic that affects everyone in every specialty of medicine. Addiction and infectious disease are intricately linked. And so I thought it would be important and interesting to cover the infectious disease complications of drug use. We're starting a little late, so I will skip through a few due to some technical difficulties. I have a lot of slides. As my husband pointed out, I put together a whole course. So I've tried to collapse that into 40 minutes and it's kind of hard to do. So I'll start with a case, and this is a case, this is my sketch. I have a few drawings throughout, so if the slides aren't interesting, hopefully the drawings are. But this is one of our patients that is very well known to us at Denver Health. She's a 46-year-old woman, and she presented to the emergency department with right lower extremity abscess and left upper extremity pain and swelling. You can see her labs in the quaint historical way that we used to write labs. And so trainees, if you don't know what these shapes are, ask your senior doctors. But basically, she was very, very sick. High white blood cell count, very high CRP, creatinine elevated. She had injected meth and heroin into her right ankle. Her friend tried to drain the abscess one day prior to admission, but then it was worse the next day. So she came to the emergency room. Past medical history, AVN, avascular necrosis, both hips, both shoulders. 2 years prior, she'd had hip replacements for the AVN. Chronic narcotic use, probably the predisposing factor. She has thyroidectomy for thyroid cancer the year earlier. History of alcohol use disorder, victim of violence and trauma her whole life. She moved to Colorado in 2017 for a job as a carpenter. She moved from New York with a boyfriend, her boyfriend, and she broke up. She was then homeless. She lost her housing. She began to use injection drugs. She was living in a tent. Her hospital course. So this will be kind of a familiar hospital course to anyone who does inpatient medicine, whether through general medicine, infectious disease, orthopedics, general surgery. She was admitted with an abscess, found to have a occlusive thrombus of her left basilic and cephalic veins. She had a TTE with a thickened mitral valve. Blood cultures positive for methicillin-resistant Staph aureus. She remained culture positive for a couple of days. Her shoulder and ankle were IND'd. Her shoulder grew MRSA, her ankle grew MRSA and group A strep. She had a wound vac. A couple days later, persistent chest pain. She got a CT scan that showed several nodules, some cavitating, consistent with septic pulmonary emboli, despite a normal TTE. She had, an antibiotics the whole time. Some pain that persisted in her left arm. CT of her arm showed pyomyositis. She had that IND'd and she had extensive necrotic debris throughout her triceps and deltoid, necrotic muscle and fascia. Continues on antibiotics, almost a 2-month hospital course, eventually has a coracotomy, pus comes out of her bone. So it's a pretty serious osteomyelitis of her humerus. Finally, after 2 months of antibiotics, stable course over the last 2 weeks, she gets a dose of dalbavancin and she's discharged to a respite. So pretty harrowing course. Over the next few months, unfortunately, about a week or two later, she was kicked out of respite, readmitted a month and a half later with ongoing shoulder osteomyelitis. This time she's Hep C positive. Her last admission, she was Hep C and Hep B negative. Now her Hep C test is positive. She has a left humerus saucerization procedure. And then she started on methadone. It's another pretty long admission of over a month, about a month. She actually winds up getting her proximal humeral head resected because it's such a bad infection. So now she's lost some functionality of her arm. Discharged. Intake at OBHS, which is our substance use treatment facility at Denver Health. Intake labs positive for hepatitis B surface antigen, which is also a new diagnosis in the last few months. Readmitted, septic arthritis, cellulitis. So really just a tough several months for Mary. I heard that she was in the hospital earlier this month, and I heard that she loves Nerd gummies, which are like a new thing. It's like gummies that have nerds on the outside. So if you have kids, they probably know about this. So I brought her some Nerd gummies and we talked and I said, do you mind, Mary? And that's not her real name, obviously, if I share your story, because I think it's so informative on so many levels about several common infections that we're seeing in the medical community right now. And she said, yes, absolutely. Tell them everything. Learn everything you can. So after that discharge in 2018, we've seen her off and on over the years, and she's intermittently been in residential rehab. She's had 2 involuntary commitments, and the doctor who committed her said, this wasn't to get her sober. This was just to save her life. She said this was like Narcan for her life. So that's why we did that last resort. In 2019, she was getting methadone, also injecting methamphetamine, skin popping, sleeping on the sidewalk. In 2021, she started smoking fentanyl, as many people did, continued to inject meth. And at that point, she was going to the Needle Exchange Harm Reduction Action Center pretty regularly, and they were really her lifeline then. So I think her story illustrates how it takes a village. Sometimes it's the primary care, sometimes it's the hospital, sometimes it's the Needle Exchange, sometimes it's our outpatient substance treatment. She was admitted recently for some cardiac issues. Fortunately, she was discharged to the Recuperative Care Center, and she's voluntarily completing an intake for substance treatment. So this is a long course dating back to 2017, but she's really had this circuitous course, and it doesn't necessarily end poorly. So what can we learn from Mary's case? Well, I'll go over in the next 40 minutes some of the pictures on this slide. This is a really good graphic about infections associated with drug use. And you can kind of see that there's things in the environment, like in the dirt, there can be spores, and that can lead to botulism, wound botulism. Of course, there's bacteria in the mouth. And so if needles are licked or wounds are licked, then that can be a source for infection. The water that people use to dissolve their drugs can be infected. So that's a source of Pseudomonas. Some dissolving agents can be acidic, and there are cases of Candida, Fortunately, that's not very common right now. Those acidic dissolving agents are really only needed for crack, and that's not the drug of choice for many people. But then, of course, it's really sterile process at the skin. That's when a lot of Staph aureus and a lot of group A strep infections happen. And then sharing blood products leads to transmission of viral infections. So this is kind of an overview slide that I'll touch on in a little more detail throughout the talk. But that's really the pathogens. And then looking at infection, there's not only pathogen, but there's also what's the host and what's the environment. And so the environment makes a big difference. Is someone using drugs in a bathroom? Are they using it outside? Do they have a stable network? Do they know who their drugs are coming from? There's so many ways that this biopsychosocial model affects the risk for infections. And then the host, not only what's the drug and what are they doing, but who is the host? How much tissue damage do they have there? How many times has that vein been damaged? Do they have endothelial damage along their heart valves? All of these things will affect the risk for infection. So you might be wondering, well, now people just smoke fentanyl. So what is injecting even still like a thing? The 2011 estimates were that around 774,000 people in the United States injected drugs. A revised 2018 estimate suggested over 3 million as a median with pretty wide confidence intervals. 1.6% of the adult population in the West, perhaps. And they basically what they did is they back calculate fatal overdose and the proportion of fatal to non-fatal overdose, and then the proportion of folks who inject who've had an overdose. So it's sort of this kind of complicated back calculation, and that's how they get to this estimate that, there may be as many as 4 million Americans injecting, at least in 2018. And if you apply that percentage to adults in Colorado, it could be as high as 70,000, which is pretty astonishing. In 2022, we had 1,600 overdose deaths in Colorado. And here's the distribution of drugs associated with overdose deaths. It was opioids with stimulants, opioids without stimulants, stimulants without opioids were the vast majority. And we know that a lot of those drugs are injected. So this just came out in MMWR recently, and it shows the transition from injecting to smoking in fatal overdose deaths. So you can see that over the last 2 years, the main mode of drug use associated with a fatal overdose death was smoking. However, this second to darkest line, as little as about a year ago, was still injecting. So a significant proportion of folks are still injecting, and we know this from our fatal overdose data. So a lot of our local data on injection drug use practices comes from NHBS. NHBS is the National HIV Behavioral Surveillance Survey. It's done at 19 metropolitan statistical areas around the country. And it's looking at HIV risk factors. So they do annual cycles. One cycle is men who have sex with men. One cycle is higher risk heterosexuals. And then one cycle is people who inject drugs. So I have a lot of data from our NHBS PWID cycle. Dr. Alia Al-Tayeb is the PI, and she's been the PI for NHBS here in Denver and the Denver Metro for the last several years. So shout out to Dr. Al-Tayeb. So here's a little bit about our 2022 NHBS sample of people who inject drugs. 70% male. Majority age 30 to 39, so probably this survey skews a little older. 75% currently experiencing homelessness, 5% living with HIV, 60% living with Hep C. They asked on NHBS cycle, the last 3 cycles, what's your drug of choice? And you can see that the orange bar is 2022. Only 29% of people said heroin was their drug of choice, which was different than 2018, which said 56% people said heroin. And even by then, we know that was actually fentanyl. But in 2022, a higher percentage of people said methamphetamine. And I think that's what really tracks with our clinical practice. And then they also asked about changes. And between, they kind of broke it down by age, but 46% of younger people and 34% of older people did switch to smoking 30% no change, and 22% switched to now mostly injecting meth. So I think that shows us that we've seen a decrease in injection, but we still have quite a bit. Okay, so a little bit about the mechanics of injecting drugs, and some of this I've learned from this harmreduction.org website, and also talking with the frontline folks at the syringe access centers throughout the state, really. So there's a lot of factors involved with the mechanics here. Partly the needle gauge. They really try to give folks encourage people to take the smallest gauge they can to cause the least amount of damage. And these insulin needles are the tool of choice. I've read about tuberculin needles and was told, no, nobody uses those. So these little insulin needles are what people use. There is a huge risk for infection with reuse of needles. So this graphic, Dr. Hurley gave me this, and it shows you the first one is a new needle after 1 use, after 2 uses, and then look at after 6 times. I mean, if a needle is reused that much, I mean, it's really just scraping in bacteria, damaging a lot of tissue. So that's a huge, huge risk for infection if needles are reused. We hear a lot about sharing, but really reuse of the same needle is a huge infection risk. The water, people can get sterile saline bullets or sterile water in little bullets at syringe access centers, like these little pink ones. A lot of people just use a water bottle and carry it around, and that can be the water for dissolving drugs, for washing hands, for drinking, not ideal. The cooker is another factor. So that's a spoon, or like sometimes like a little cap that can be balanced, and that's where the water and the drugs get dissolved. Sometimes the heat source is needed, and with some powders, the heat source isn't needed. There's also the syringe. Is it a single unit with the needle and syringe attached, or do they come apart? Because if they come apart, that's another infection risk. On the other hand, it can be easier to switch out needles. People like to get a big gauge to draw up and then a small gauge to inject. So, you know, things I think worthwhile for us to know about. The filters, so after people dissolve their drugs, they pull them up through a filter. The filter, the ideal filter is a cotton, sometimes Q-tips. There's a lot of talk in harm reduction about be sure people aren't using tampons, they have a lot of chemicals, or be sure they're not using cigarette butts because they have glass. So just think about how damaging that would be to vessels. There's risks when dividing drugs, and then alcohol pads, wipes, and gauze. Really, how much people have alcohol pads and how much they have single-use needles is really dependent on how prevalent harm reduction sources are. So when people come from Wyoming, when there's no harm reduction, that's when people don't use alcohol swabs. How busy, how frantic people are, then you know that all kind of plays into the likelihood of getting an infection when they pierce their skin. Muscle popping is IM injection. Skin popping can be sub-Q or intradermal. So the presenting complaint that Mary came with was an abscess, and this is by far the largest number of infections that we see. This is just an up-to-date schematic of abscess versus cellulitis. There's a lot of cellulitis, a lot of abscess, you know, several 100,000 annually. The NHBS data asked about abscess risks, and they found that in the 2018 and 2022 samples, have you ever had an abscess? 66% of people who injected said they have had an abscess. How often have you had an abscess in the last 12 months? Over 50% said they had had at least one in the past 12 months, with some folks having, you know, more than 3. And then what did you do to treat it? So that's really pretty widely distributed. Some people just write it out. Some people have a friend lance it or lance it themselves. 32% in this last cycle saw a medical provider. And some people took antibiotics without a prescription. And then thinking about risks for abscess, how often do you clean your skin with an alcohol swab? And that's also pretty widely distributed. Some people said always, some people said never. And after I thought this was interesting. We hear a lot about, do you lick the needle? And I usually talk to patients on the wards, you know, did you lick the needle? And often they say yes, which surprises me. But a lot of people also reported that they, if they need to stop the bleeding, sometimes they'll suck their arm or just use an old shirt. So, you know, again, another infection risk. And then we looked at like data on how often have you used a needle after somebody else, or how often have you reused your own needles? And the NHBS data suggests that most people actually in the Denver area are not reusing needles. About 70% are using a fresh needle every time, which again speaks to the strength of our harm reduction services here. I've even read about resharpening needles on rocks in places where they're not widely available, and then they can get a little burr that can break off. So really some pretty scary stuff, and speaks to how important it is to have these services available. So abscess management, prevention, we'll talk more about that. We've already talked a little bit about it. It's important for people to consider warm soaks if they're not going to get medical care. Antibiotics, the old dogma was if you IND an abscess, it's fine. You don't need to treat. But now there's several studies showing that antibiotics make a big difference. And I think in folks where follow-up is so iffy, I think it's important that we have a low threshold for giving a 5-day course of antibiotics for cellulitis and abscess. You should know your local antibiogram. Here's Denver Health's. So here's some of the antibiotics that we use for skin infections. Clindamycin, doxycycline. You'll note that for MRSA, our rates are not as high as we would like them to be for efficacy, for percent of isolates that are susceptible. So Bactrim is our highest efficacy among our Denver Health isolates, and I encourage you to look at your own antibiogram to think about what you want to prescribe. Bactrim is cheap and it works well, so 5 days of Bactrim is a good treatment option, sometimes doxycycline. Consider the timing. If you're going to get an IND, you know, ideally you'll culture first and then give antibiotics. If someone is septic, go ahead and give the antibiotics right away. And then IND makes a big difference. You might be tempted to just stick a needle, but there's a 74% failure rate from needle aspiration alone. So if you see a cutaneous abscess, it really needs to be drained. Consider blood cultures if systemically ill. Around the country, there's new reports of abscess clinics and wound care clinics, mobile units, on-site at syringe access centers or near syringe access centers. I think there's a lot of promise there. There's also a lot of logistical and legal challenges, but that I think can make a big difference because coming to healthcare can be so challenging for people. And then it's really important that we educate our patients on the warning signs of sepsis. So I'm doing a telehealth program that I'll tell you about in a couple slides. And I've seen a few abscesses. I've prescribed some Doxy and Bactrim, but I get really worried about undertreating endocarditis. So I think it's really important that we're doing shared decision-making and really encouraging folks, if you have a fever, mental status change, shaking chills, tachycardia, please go get medical care because it could be sepsis. So moving on to serious bacterial infections, Tim Jenkins and I pulled some data a couple of years ago looking at the rate of serious bacterial infections associated with injection drug use at Denver Health. And in a 1-year period, it looked like we may have had about 241 hospital admissions for serious bacterial infections associated with injection drug use. 178 cases of cellulitis, soft tissue abscess, 39 osteomyelitis and septic joints, bacteremia, and 24 cases of endocarditis. And interestingly, there's been some talk about endocarditis committees so that we have sort of a multi-dimensional discussion about whether people need valves or what's the best treatment for endocarditis. I talked to our cardiologist at Denver Health, who's really spearheading this committee, and he said, we're so excited, but we haven't seen any in the last year. So we really have seen a decrease in endocarditis as there's been a transition to smoking. It's really terrifying for overdose, and it's truly harm reduction though. So around the country through 2018, we saw pretty big increases, just as we did at Denver Health, and I would assume at the university, in admissions for serious bacterial infections. This is some data from North Carolina, data from Oregon, Michigan. They looked at a 3-year period and they looked at all ICD codes for substance use. And then they did the Venn with serious bacterial infections, and they found that there were 23,000 overlaps in 3 years. So quite a few admissions for serious bacterial infections. Lifetime risk, pretty high for abscess and endocarditis, a little lower for osteomyelitis. When we think about the spectrum of treatment for these serious bacterial infections, it's a big challenge because you'll note in this third column, the duration of antibiotics is typically 4 to 6 weeks, a little shorter for septic joints, obviously shorter for cutaneous abscess, cellulitis. Often debridement is needed. These are pretty complicated and challenging infections. And this is kind of the range of the most common injection-related infection, serious bacterial or fungal infections, endocarditis, pleural empyema, osteomyelitis, epidural abscess, cutaneous abscess, necrotizing fasciitis, necrotizing muscle infections. They're typically hematogenous spread, although like this picture in the top, they can be from direct inoculation or local spread from an infection like the case that I described on the ankle. Septic emboli and empyema are common. Septic emboli in the lungs don't always mean endocarditis. There could be a septic thrombus somewhere in the body, but this is a pretty common complication as well. So looking at those long courses of antibiotics, what about IV antibiotics at home? Can we do OPAT for people who inject drugs? The OPAT kind of came about in the 70s for folks with cystic fibrosis, and it was really, great for patients not to stay in the hospital for so long. The 2004 IDSA guidelines said, no way, no sir, don't do it. 2018 updated guidelines said, well, if people have substance use disorders, consider it on a case-by-case basis, which is really, I think, where we're all at now. It's really challenging. There was a literature review that looked at 10 studies of OPAT, outpatient IV antibiotics for people who use drugs. And they found that there were success rates of 72 to 100%. Line complications were fewer than 10%. Tampering doesn't seem to be commonly reported, and there's different ways of approaching tampering, but I think that's maybe an overblown concern. But there's still a lot of challenges, and these were pretty small retrospective studies. One of the studies was done in Harborview, Seattle by a PA who used to do orthopedic infectious disease at Denver Health. And she found that among folks who had complete outcome data, the results were equivalent for people who used drugs and people who didn't. But if you consider loss equals failure, then people who use drugs had poorer outcomes. So they also looked at, well, what about if you go to a respite or a drug treatment facility or a SNF? And that didn't seem to be protective. So I think this really speaks to the challenges of IV antibiotics for outpatients, and not to say that it can't be done, but it's very case by case. Okay, really exciting stuff in the world of infectious disease, oral antibiotics for serious bacterial infections. So the old dogma was kind of antiquated and not as evidence-based as we would have liked, but they said, you need 4 to 6 weeks of IV antibiotics for osteomyelitis. These were based on studies of older antibiotics with poor bioavailability. And even our 2015 endocarditis guidelines say, consider 2 to 4 weeks for right-sided endocarditis caused by MSSA. You could consider a combination of equinolone and rifampin, but really left-sided endocarditis, 6 weeks IV antibiotics, and that's the standard that our guidelines have shown. Newer data, fortunately, there have been now 8 RCTs for osteomyelitis for IV antibiotics versus oral, mostly fluoroquinolones, and they've all shown equivalent outcomes with oral antibiotics versus IV. Peak levels of the peak blood levels of the antibiotics are reaching MIC ratios that are greater than 1 for the pathogens that are present. And then for endocarditis, it's a little more complicated. There have been 3 RCTs and 1 pre-post study looking at step down, which is very different than saying oral antibiotics are fine. This is step down from IV to oral. And they have all found, again, equivalent outcomes or better with oral antibiotics. So the 2 trials that have really been the sentinel trials that have changed our management and really affected how we care for people who inject drugs. The Oviva trial was done in the UK, 1,000 participants, 10-fold higher than anything else that had been done before, larger. And they found that after no more than 7 days of IV antibiotics, with a switch to at least 3 weeks of oral antibiotics, that oral antibiotics were non-inferior. So that was pretty cool, but again, a wide variety of oral antibiotics were used. And then the POET trial looked at oral antibiotics for endocarditis, left side endocarditis. They did 17 days of IV antibiotics. So this is not exactly like a short hospitalization. And then they stepped down to combination oral antibiotics. They used 2 antibiotics plus They used like a fusidic acid or clavulanic acid or rifampin. And they followed people up 2 to 3 times a week, which is more than we see people on IV antibiotics now. And they also found that oral antibiotics were non-inferior. So this was a terrific sketch done by a fellow for Journal Club at MGH, and probably more journal clubs should be that way, in my opinion. Person after my own heart. So some issues. So this is really interesting data, and it gives us some relief that we're not just doing a Hail Mary pass, just hoping for the best with oral antibiotics and doing damage control, but that actually we may be giving a new standard of care when we discharge people with oral antibiotics. In the Oviva trial, there was 14% failure in both arms. So this is a high failure, high mortality, high morbidity, I should say, with osteomyelitis. And they didn't report how many people used drugs in their study. And they had no staph bacteremia. So we can't exactly apply this to a lot of our cases of osteomyelitis. The POET trial, they had no methicillin-resistant Staph aureus, and only a couple people who used injection drugs. So again, this is not like a perfect study for our purposes. And they did a TEE prior to switch, so they really felt confident that they didn't have any worsening endocarditis. And then all this close follow-up. So I think these are things to consider and things that we consider on every single case that we see now. What about drug interactions of these oral antibiotics with the medications that we use for substance use disorder? We used to worry a lot about giving somebody rifampin if they were on methadone. The three common antibiotics that do have drug interactions are fluoroquinolones, linezolid, rifampin, and they all can be managed. So there's no hard stops here with people who are on substance treatment, but it really should be discussed with ID because there are some pretty serious considerations. This was a real world study I'm going to skip over, but it showed that, yes, oral antibiotics for endocarditis did work very, very well. And this just came out last year. The last thing I'll mention about bacterial infections is about dalbavancin. These are long-acting lipopeptide antibiotics, sort of in the vancomycin family. They're FDA approved for SSTIs, but there's a lot of data, including some local data that I highlighted, using these for serious bacterial infections for people who inject drugs. Very promising. The challenge is that these, they last, like dalbavancin, it lasts 7 to 10 days. So if you want to treat a whole course of a serious infection, you have to have people come back. And that's really challenging. So the niche so far has been shortening a hospitalization by 7 to 10 days. And not to mention that it is inferior treatment for MSSA, we know. So finally, reducing patient-directed discharges. So this is an interesting study that they did in Missouri where they were worried that they enrolled 166 people who injected drugs, and they kind of had like a game plan. So they're really proactive, trying to get folks to stay engaged, stay in the hospital. 37% completed IV antibiotic. Sorry for all the noise. 63% had a patient-directed discharge. We say AMA, against medical advice. The correct term now is patient-directed discharge, which is in recognition of how complicated people's lives are. And we know the medical perspective, but patient-directed discharge is more friendly. I personally have a hard time remembering to say that. AMA flows a little easier. But they had, with kind of this proactive approach, a lot of people left patient-directed discharge on oral antibiotics, and they had excellent outcomes. So it's something to consider. All right, switching to, in the last 15 minutes, viruses. Looking at Hep B and Hep C. This is a tragedy. This is a real person. And between when she was admitted the first time and the second time, she got hepatitis C and hepatitis B. So she has had an intermittent course. Hepatitis B has been treated with TAF, which is tenofovir alafenamide. You should start Hep B treatment before Hep C treatment. Really complicates the Hep C treatment. So it's really a missed opportunity for prevention because she didn't get a vaccine. And she's been treated. She's been reinfected for Hep C. It's kind of a mess, but we're getting there. And I think that's kind of the take-home point of the whole talk. Stay engaged because we will get there. Hep C has gone up in the last decade, even though we have cures that are super easy to take now. It's heartbreaking. But there are probably close to 100,000 cases of acute hepatitis C per year. It really went up with the injection drug epidemic. Unfortunately, going the wrong direction. Hep C causes a lot of mortality. Aside from COVID, more deaths are caused by Hep C than any other reportable infectious disease. So Hep C is a really big deal. And 80% of new cases are related to injection drug use. And we will not see epidemic unless we treat people who use drugs. Easier said than done. So looking at it back to our NHBS questions, our local data on people right here in Denver who have you ever taken a medicine to treat Hep C? 37% said yes in 2022, which is an improvement. Interested, 65%. Sorry about all the thinking. I don't know if I should mute something, try to power through. But Hep C treatment has changed. So I work in public health, and this was one of our ad campaigns a couple of years ago. We had this on billboards, we had it on posters everywhere. Hep C treatment used to be a year, now it's 8 to 12 weeks. It used to be toxic, now it's not toxic. Sobriety is not required for treatment, and it's 95% effective in real world studies. If you take it as prescribed, it's over 99% effective. So Hep C it's a total revolution. These are as David Wiles, who I work with, says there's no bad options now. We have trade name Mavorette, which is a combination of 2 different medications. Epclusa, combination of 2 different medications. They're pan-genotypic, super effective. Side effects are minimal. We know from this MinMon trial, which was really cool, that you can do labs up front, give people the whole course of medication, which is going to be 8 to 12 weeks. Don't mess with them. Don't bother them. Maybe call them to check in, but you don't need blood work. And then 3 months after they're finished with their meds, check to see how they did. And 95% of people got cured. So, and that was done all around the world. So these meds are pretty easy to use, very, very low barriers, the way we should be going. This algorithm is available at hcvguidelines.org, and it's a simplified algorithm that's really idea is to get everyone treating. So our treatment protocol, which is based on the national guidelines, is, do they have Hep C? You need to make sure that they're not just antibody positive. Do they have, is there RNA positive? Are they not cirrhotic? Are they treatment naive? Okay, primary care can absolutely treat. Get a CBC, get LFTs, calculate a FIB4. There's the equation. It's available on all the calculators. Get a Hep B surface antigen, because there are multiple reports of people who had untreated Hep B, who got Hep C cured, Hep B flared. Why that happens isn't totally understood, but there's probably some intracellular competition or immune reaction that happens when Hep C is cured. So if you have somebody who has hepatitis B, don't treat in primary care or refer, because it needs to be done through a specialist. But fortunately, hepatitis B is much less common than Hep C. So get your surface antigen. Is their FIB4 less than 3? Are they Hep B negative? Are they not pregnant? Okay, what medications are they taking? There's a few drug interactions to consider. The pharmacist can help you. There's really only 4 or 5 major ones. If no major drug interactions, then start treatment. Glecaprevir pibrentosphere or sofosbuvir velpatasvir, that's Mavorette, Epclusa. You can't go wrong. They're both pan-genotypic. They're both 8 to 12 weeks. And then let them finish their medications, wait 12 weeks, check for SVR. Little caveats along the way, and I can share this with you if you'd like, but it's pretty straightforward. And we don't even have prior authorization anymore for Medicaid. So if you have a patient with Medicaid and you know that they're RNA positive and they're Hep B surface antigen negative, just write the prescription. Pretty cool, pretty easy. If they're uninsured, we have patient assistance programs. If they have commercial insurance, you may have to do a prior auth. All that said, we'll be presenting this at CROI next week. This is a multi-site study that I've been fortunate to co-lead, looking at Hep C testing in emergency departments around the country. And we found a lot of Hep C. And our second aim was to say, well, of the Hep C we diagnose in the ER, how about treatment? Our treatment rates are pretty low. So we looked at a navigator versus just clinician referral alone. And we found even with a navigator, for people who use drugs, only 12 out of 58 people with the navigator engaged in care. Only 6 started Hep C treatment. So fewer than 10% with a navigator with all these barriers removed. And that really tells us that we've got a long way to go treating people who inject drugs. The NHBS study asked, where would you be more likely to get your Hep C treated? And you can see the results up here. People said primary care, specialty clinic, which is the current standard, not very popular. Methadone or Suboxone clinic, we've had excellent results there. And then the syringe access program was definitely seen favorably. And I think emergency departments are also the new frontier. It's what I've learned from Detect Hep C, our big ED study. So that obviously hasn't been asked yet, but I think that's something we should consider as well. So looking at syringe programs, this study out of New York proved what we thought would be the case, what the NHBS survey data suggested. They randomized people in New York to either get treatment at a syringe access center, including one all the way across town, or usual care clinic. And the treatment rates, you can see that accessible care is the light blue bar. They blew usual care out of the water. So clearly getting treatment for Hep C at a syringe access center is highly preferred, even if it means you have to go across town. It really speaks to the comfort and the vibe of the environment. So this is a picture of the Harm Reduction Action Center where I've worked a lot. They see 180 people per morning. They're the largest syringe access center in Denver. We did a survey and we asked lots of questions about interest in telehealth and interest in, would you like to get Hep C treated? And just this small bar up in the far corner, if you could get your Hep C treated here, would you be more likely to? And 70% said yes, and another 18%, yeah, probably. So I think there's no question that we're going to have progress if we can meet people where, as they say, where they're at. So here's our protocol for Hep C treatment at the needle exchange. People drop in for their supplies. If they're Hep C positive, they can go see us. So there's this little back room, pretty low tech, do a video visit, get enrolled, get on the drop-in schedule. We have an on-site phlebotomist who's really well trained, and he's able to get blood from anyone, bring the labs back to Denver Health. If they're Hep C positive, then I can write a prescription. Our pharmacy mails it to the syringe access center. They store it, and then people pick up the meds when they need to get supplies anyway. They'll pick up a week or a month at a time, whatever works for them. They do have a gift card, and so far it's been pretty popular. We've enrolled 56 people in about a year, a little over a year. 16 actually were RNA negative, so a lot of people don't know if they have Hep C or not. But so far we've gotten SVR cures on 12, 5 are awaiting labs, 5 more on treatment. And then we have some people lost to follow-up. So we've been really low barrier. Some of the studies have shown, we offer this to people who are consistently engaged. We'll offer this to anyone. This was a CDC site visit. CDC is funding this project, which is pretty cool. But it's not perfect, but it's something. And I think we've seen a lot of progress. Mary was reinfected. I'll skip this. Reinfections happen, but they're actually pretty rare. 6 per 100 person years is what we've seen. Hep B, much more difficult to treat. I mean, the life cycles pictures show that, hepatitis C is never going into the nucleus. It doesn't incorporate, it doesn't have latency, it's curable. Hep B goes into the nucleus, makes a circle of RNA, and it has DNA, and it has latency. So Hep B it's not curable, it's a lifelong treatment. So we really need to be thinking about vaccines. Heplisav is the vaccine of choice now for people who inject drugs. If you look at the dosing on this far column, you'll see that it's only 2 doses, 1 month apart, highly effective. Please, please encourage your folks to get Heplisav and do what you can to get Heplisav to your patients, because we've seen Hep C is out there. Not only did Mary get it, but several of her injecting partners did as well. So in the last 5 minutes, 5 to 7 minutes, what else? Those were the big things: bacterial infections, viral infections. Obviously, HIV, botulism, syphilis rates have gone up among people who inject drugs, and then infections with homelessness, I'll just touch on. So HIV, we've seen a lot of clusters. There's also been an increase in percent positivity that CDC has reported. So HIV is something we should certainly be thinking about. It's largely driven by sex, but a lot of people do still get HIV through injection drug use, and people who inject drugs have sex too. So HIV is very, very prominent in this community. two models that are highly successful, and well, they're getting there. They're highly successful at improving HIV outcomes for people who use drugs or substances. Dr. Kelly Hawkins has the DACE clinic, which is direct access to care. It's based on the Max Clinic model out of Seattle. They will offer low barrier drop-in for people with adherence challenges, and generally 100% of people have substance use disorder. There's a dedicated ID physician, which is Dr. Hawkins, and there's a case manager who's available to help people with a wide variety of things. They give milestone incentives, and they have a lot of logistical support. And so Dr. Hawkins has already seen good improvements in viral suppression for people in the DACE clinic. And the Public Health Use Disorders Clinic is run by a physician who's trained in addiction medicine and is really on the front line. Her primary assignment is in our addiction clinic. And then she also sees patients in our HIV clinic who have substance use disorders. And there's a certified addictions counselor. And so co-locating these two things has made a big difference in HIV outcomes. I'm going to skip over a little bit about PrEP. PrEP is really underutilized by people who inject drugs. I think most of us who are in public health and in the harm reduction community are not really pushing PrEP, but it's really important that we at least tell people about it. And there are some pretty amazing models of how PrEP can be effectively offered to people who use drugs. Dr. Sandy Springer from Yale will be here in a couple of months, and she's going to talk about some cool outreach programs and ways that they've been able to incorporate HIV care and PrEP with substance treatment. So Boston Healthcare for the Homeless had a really low threshold approach to PrEP, and they got 152 people prescribed PrEP who were homeless and injecting drugs. It's a pretty amazing improvement. One slide about botulism. This happens. People have descending paralysis. This is a wound botulism. People inject spores. The spores then, release toxins, botulinum toxin. It's rare, but it's terrifying and life-threatening. So if you see someone who injects drugs and they seem drowsy, maybe they're not just overly sedated and not engaging. They might actually have something more serious going on. If you have any evidence that they have weakness, do consider botulism. Again, it's not common, but if we act quickly, we can really decrease damage. Homelessness, I won't go into the epi because we all know how bad it is, but it has gone up dramatically in our community. This study showed that among hospital patients at one point in time when the city was counting, they also counted in Denver Health and University and found that 29% of our patients were unstably housed. Homelessness is common among people who inject drugs. And then, there are some infections that are associated with homelessness like frostbite. We see a lot of osteomyelitis after frostbite. We see Hep A outbreaks. We're just hopefully coming down from a Neisseria meningitidis outbreak. We know that there's high rates of Bartonella quintana among people experiencing homelessness. So do keep these things in mind when you're taking care of people experiencing homelessness. Also, we see really poor wound healing. I just saw a woman with a fasciotomy from a year ago, and it still hasn't healed. So these are real big challenges. This is where people are trying to recover. So a lot of people inject drugs, people who are homeless, not an easy place to recover. You can really see how Maslow's hierarchy of needs is the reality that people are living right now. So there's different options. The RCCs are amazing. Housing dramatically improves HIV and Hep C outcomes, and that was shown in a study in Washington, D.C. Again, since we started late, I won't go into overdose, but we know that this is the #1 crisis. It's like the early days of the AIDS epidemic when you think about how many people are dying. Offering naloxone, offering fentanyl test strips, and offering referral to treatment for people who want it every single time we can. But because the overdose crisis is incredibly, incredibly heartbreaking. Xylazine is something that we're hearing more about. This is not an infection. This is a toxin. This is a toxic effective medication. This is a sedative that a lot of drugs are cut with now. It's been a big problem on the East Coast. Fortunately, we haven't seen much xylazine out here. There are test strips available so people can test their drugs for fentanyl. They can test their drugs for xylazine. I won't go into it. If you're interested, reach out to me and I can send you resources. There's a great review of how to treat these wounds in Journal of Addiction Medicine, but it's just something to be aware of that these are non-infections, but they're horrible. There was a paper that suggested that we have like a checklist, and I don't think any of us can do a checklist when we take care of patients because they're so complicated, but at least some things to consider when you take care of people who use drugs. SUD treatment, harm reduction resources, ID screening, vaccines, contraception. 80% of the pregnancies are unwanted, or not unwanted, I'm sorry, unplanned. And then consider PrEP. So one slide about stigma. There's a lot of problems. People don't want to go to the ER because they get treated like a drug user. Best satire of our time. The Simpsons can explain it, talking about Napian instead of Ambien. But, the drug war is really based on a lot of xenophobia and racism. We know that DARE didn't work. We knew it as early as 1994. So unfortunately, all the societal messages are pretty stigmatizing for people who use drugs. And then thinking about alcohol. Alcohol has a much higher burden of morbidity and mortality, both high amounts of alcohol and even moderate, what we consider low consumption, is still associated with cancer. And so we're seeing quite a disparity in terms of volume of damage societally from alcohol injection drugs. And I think there's just kind of a double standard when it comes to how we treat people who use moderate to severe amounts of alcohol. Not to say that our approach to alcohol has worked, but I think we should kind of check our biases when we think about alcohol. So I'm going to go over just harm reduction, the idea that we're treating people for who they are, where they are, what they need at this moment, not what we want them to be, not anything contingent on sobriety. And that's really the tenet of harm reduction. We have several in our state. We're fortunate. We actually probably provide a lot of services to people in surrounding states. They do so many different services, including a trash pickup, which is shown here. Harm reduction, there's vein classes. They do so many different steps. So in summary, a couple of resources that I found really interesting. This Harm Reduction Gap is a fantastic book. It just came out, but it's really, really insightful. How to talk to teens about drugs. This is a harm reduction podcast. It's not a DARE sobriety podcast. But IDU is common. Homelessness increases infection risk. There are a lot of things we can consider, like planning ahead, oral antibiotics, low barrier approaches, and harm reduction, and checking our own biases. So with that, I did get through it, even though we started late. But thank you to all the people listed here. I have a fantastic team that I've been able to work with in public health, in the community, and the hospital over the years. And if we want to stay over, I'm happy to answer any questions. Thank you.
That was wonderful. Amazing that you got done. Thank you. I'll take questions from our audience first. Yeah, Dr. Stenya.
So thank you. That was absolutely wonderful. I'm curious, has Denver Health embraced the oral antibiotic paradigm shift and worked on getting patients that inject drugs with invasive infections out of the hospital on oral therapy to get them engaged into substance use treatment centers? Or is still the prevailing theme to keep them in the hospital for longer courses of IV antibiotics because you can't get them into substance use centers?
So the question was about how much are we using oral antibiotics for serious bacterial infections? On the orthopedic side, extensively. They're really their number one go-to. OPAT is so complicated and oral antibiotics are so good that we've really, really switched to oral antibiotics for osteomyelitis, septic joints. No question. Endocarditis is more tricky. And again, we haven't had as much recently, but we're definitely seeing some septic pulmonary emboli suggesting right-sided endocarditis. But we're switching to earlier transition to oral antibiotics as well, rather than we tried to do a pilot with a sobriety house, and it was really challenging to do outpatient IV antibiotics, but the recuperative care center is an option for people who have challenges. They can get IV antibiotics there. So I'd say for endocarditis, it's a hybrid. And then everyone at Denver Health, and I think here too, gets an addiction consult. If they don't want it, they don't have to talk to them, but a lot of people start methadone inpatient, and we have a very effective transition to outpatient methadone and Suboxone care, which we know is hugely impactful for decreasing infections.
We are right at 1 o'clock, so I think we'll stop there. But Dr. Rowan, thank you for an excellent grand rounds.
Yeah.